Great. And I am going to move right over to introduce Dr. Longenecker, who I'll put a plug in, has also been involved with our exercise work from the cardiology standpoint. So he hopefully is also a strong proponent of exercise as a way of preventing cardiovascular disease as well as frailty. We heard a little bit from Dr. Longenecker on the vaccine panel. So you already know that he is a cardiologist, but he's a non-invasive cardiologist and professor in the Division of Cardiology and Department of Global Health at the University of Washington School of Medicine. He is the inaugural director of the Global Cardiovascular Health Program, a joint initiative of cardiology and global health. He attends on the Harborview Cardiology Consult Service and is director of a unique HIV cardiology clinic within the Madison Clinic at Harborview. His research, which is primarily conducted in the US and Uganda, focuses on mechanisms and prevention of cardiovascular disease in people living with HIV, with a secondary focus on quality of care and outcomes for people living with rheumatic heart disease. His research is funded by the NIH, the American Heart Association, and the Medtronic Philanthropy. And he's going to present on overcoming clinical inertia to improve heart health. Dr. Longenecker.
Thank you so much, Christine. It's really a pleasure to be here. We're going to be talking about how to overcome clinical inertia. And I hope you'll learn something from this talk today. These are my disclosures. And these are the learning objectives. So we hope today to describe the epidemiology of cardiovascular disease in adults aging with HIV. Secondly, to apply risk prediction tools to guide shared decision-making with patients about statin therapy. We'll talk about managing blood pressure using a risk-based approach, and then list factors to consider when prescribing aspirin for adults aging with HIV. So a lot to cover, but I think we'll be able to do that in 25 minutes together. I'd like to start with an exercise that hopefully will inspire you. This guy on the left is named Greg. And the woman on the right is Marissa. Greg is 65 years old, and he's had HIV since 2002 and has been on ART ever since then. His nadir CD4 count was quite low at the time that he was diagnosed, but is now back to 600. Whereas Marissa is also 65, but she was diagnosed with HIV in 2010 and has been on ART since. And when she was diagnosed, her nadir CD4 count was 600, so she did not have as advanced HIV disease. Now, when we think about their cardiovascular risk, what else do we need to know? Well, they both smoke, so that's contributing. But Greg here has a blood pressure of 140/70 on amlodipine 10 and has an LDL cholesterol of 100 on atorvastatin 40. Whereas Marissa has a normal blood pressure, borderline normal blood pressure, and an LDL of 100 on atorva 40 as well. Okay, so who is at higher risk of cardiovascular disease? For a number of reasons, we would all probably agree that Greg over here, he's had HIV for a longer time, he's been on ART longer, he had a lower nadir CD4 count. He probably is at higher risk. But here's the kicker. Sam here is also 65, but he's HIV negative. He also smokes, but because he doesn't have a chronic disease and doesn't think he needs a primary care doc, he's walking around with a blood pressure of 150/90 and an LDL cholesterol that's untreated of 160 milligrams per deciliter. So now who is at higher risk? I would argue that it's Sam here in the center, and that because these two patients with HIV are engaged in care, they have the opportunity to have excellent cardiovascular disease prevention care. So with that, let's talk about the epidemiology. So HIV is a risk factor for cardiovascular disease. We all know this. We know that the risks for myocardial infarction, stroke, and heart failure are all increased, and that risk, the HIV-specific relative risk, is higher in women than in men. And we talk a lot about inflammation and immune activation and HIV-specific factors such as elevated viral load or low nadir CD4 count. But when it comes down to it, on a population level, it's really the traditional risk factors, total cholesterol, hypertension, and smoking that play the most important role on a population level because they're much more common than the HIV-specific risk factors. So now we can leverage this to extend the HIV treatment cascade for cardiovascular disease prevention, because so many of our patients have achieved viral suppression in that final step of the HIV care cascade that we now need to turn our attention towards the prevention of non-AIDS comorbidities such as cardiovascular disease by appropriately diagnosing and managing high blood pressure and then pushing those drugs to reach blood pressure and cholesterol goals. But we have challenges in HIV, and at least in the United States, one of the issues is that there's confusion sometimes about who's actually responsible for doing these things, right? This study from Duke, published by Lanzokeke and colleagues, looked at hypertension and hyperlipidemia and found a smattering of different providers providing those medications. So in some cases, it's infectious disease. In other cases, it's primary care. In many cases, it's really nobody is prescribing anything, which is obviously a bad situation. And in fact, when they looked at blood pressure control, they found that when infectious disease was managing the blood pressure, there was a 16% lower chance of control compared to primary care after adjusting for the confounders that they had access to. Of course, possibility of residual confounding, but nonetheless, an intriguing finding. So, how can we now use risk prediction to guide shared decision making on statins? So, I'm going to start with a clinical case. This is a 59-year-old with HIV. You can see his numbers there on dolutegravir, TDF-FTC. And he's an avid smoker who got a low-dose chest CT for lung cancer because of his smoking. And this chest CT showed three-vessel coronary calcification. He has, besides the smoking, relatively high cholesterol, although not that bad. His father had a coronary bypass at age 60. You can see his medications, his current blood pressure, and other labs were fairly normal. All right, so what do we do? How do we prevent cardiovascular disease in this patient? Because this patient, although he has coronary calcium on his CT scan, has never had an ASCVD event. So in 2018, we had essentially guidelines that said there are four buckets to put people in when considering statin therapy. One, those who have clinical ASCVD, which he does not because he's never had an event. Those with LDL cholesterol greater than 190, he also does not fall in that category, and those with diabetes. He also does not have diabetes. So the next step for him is to really calculate an estimated 10-year risk, and if his risk is high, to consider statin therapy, perhaps after additional risk factor assessment and calcium. So these are the pooled cohort equations that were recommended in the 2018 guidelines. These were developed in 2013. And you can see all the different elements that go into it. For him, his current 10-year ASCVD risk is 17%. But as many of you may know, there's a new kid on the block called the PREVENT equations. These were, again, developed by the American Heart Association. And they're different in that the race term was removed, recognizing that race is a social construct and maybe not the best thing to use for a risk prediction tool. It also added markers of cardiovascular kidney metabolic risk, things such as kidney function, GFR, but also urine albumin to creatinine ratio and BMI. And then added social determinants of health using social deprivation index, zip code SDI, as a surrogate marker of SDOH. And then the other change is besides what goes into the equations is that the PREVENT equations also predict heart failure outcomes, not just ASCVD events. And these are all the elements that go into the calculator. You can see the URL there to get to it. So what do we know about PREVENT in HIV? The study published earlier this year shows that the pooled cohort equations actually do a much better job in terms of calibration in predicting risk compared to the PREVENT equations. And in fact, PREVENT underestimated risk in HIV by over twofold. This was seen not only in the CENIX cohort, but also in the REPRIEVE trial. This study just is currently in press, comparing the PREVENT equations to the SCORE equations, which are used in Europe a lot. You can see that there's a significant underestimation of risk across all the different strata of risk in PREVENT. However, I would add that if you compare PREVENT to PC, and again, this is from the REPRIEVE study, that when you look at very low levels, so less than 5% 10-year risk, you can see that Prevent actually does a little bit better job at risk stratifying within that. So you can kind of see the separation of these curves from the Reprieve data, whereas for pooled cohort equations, you don't really see that. So maybe Prevent has a little bit of a role to play for those lower levels of risk. Now, going back to the 2018 guidelines, we have had in the guidelines since 2018 a recommendation to consider HIV as a risk enhancer, and that if ASCVD risk is greater than 5%, that if risk enhancers are present, then we should consider statin therapy. And if kind of in this intermediate risk zone, if there still is hesitancy or the risk decision is uncertain, doing things like measuring coronary calcium was recommended. But now we have Reprieve. So Reprieve was obviously a randomized controlled trial, placebo-controlled trial of pitavastatin, and we see the 35% reduction in major adverse cardiovascular events. So now we have new guidelines for HIV that would suggest that for all people aged 40 to 75, particularly for those with 5 to 20% risk, and again, they use the pooled cohort equations for this, that we would consider statin therapy, moderate intensity statin. And for less than 5%, considering additional risk factors, such as the presence of HIV-specific risk factors like low nadir CD4 count, is important. And it's important also to recognize that while this is a course on aging, for those who are less than 40 years of age, there really is insufficient data. And just to drive home the point that for those who have a 10-year risk less than 5%, the number needed to treat is actually relatively high on the order of 130, 187. Again, using the pooled cohort equations for this study. All right, can we refine risk further to identify people who would benefit the most? And we've mentioned this, but I want to talk a little bit more in detail about coronary artery calcium. So the case I presented was actually a non-gated scan of the lungs for cancer screening. And that can give you a qualitative sense, but because of the motion of the heart, what you really need to do is a ECG-gated CT scan of the chest to accurately quantify the amount of calcium. This is different than CT angiography. You may have heard coronary angiography, which requires IV contrast and can tell how much luminal narrowing there is. But it does give a very good overall assessment of the total burden of atherosclerosis. We know that for people with a high calcium score greater than 400, their 10-year risk is considerably high, over 20%. But the other thing about calcium scoring is that it's really, really powerful tool to de-risk someone. So if someone has a calcium score of 0, their 10-year risk of a CVD event is actually quite low. And this may be useful in many cases. So we talk about the power of 0 of coronary calcium scoring. Back to our case, as we could have predicted, when we did formal calcium scoring, his was quite high, and he ended up getting coronary angiography at some point because of some symptoms he was having, and you can see he had 3-vessel coronary disease. So that's just one example. There are other ways to risk stratify people, and including lipoprotein little a. And I'm not going to go into great detail, but happy to address this in the Q&A if people are interested. So it's really important to do shared decision making around statins. As we all know, you can use tools to help people understand risk, such as the statin decision aid from the Mayo Clinic, to always begin with lifestyle, to not just begin with statins and push statins from the beginning, but to start with lifestyle, and then to include patient costs, especially if you're considering other newer cholesterol medicines such as PCSK9 inhibitors or others. And to make sure the patient feels heard, has a chance to ask questions, and owns decisions. Again, just a review of the statin intensities. Pitavastatin is a moderate intensity statin. That's again what's recommended for primary prevention. However, we may need to use high intensity statins in people with established cardiovascular disease or a very high risk. Let's talk a little bit now about hypertension. So many different factors contribute to hypertension in people with HIV. Some of those are shown in this graphic, but I'd just like to point out the RAS activation. There's been a lot of study of that, Steve Grinspring's group and others. and want to come back to that later in terms of how that might affect treatment. We know there are new hypertension treatment guidelines on the block as well. These came out in the end of August, early September. So I would encourage you to take a look at them if you haven't already. One of the things, the take-home message is that the absolute risk of hypertension depends on the absolute risk of total CVD. So other risk factors are important. You can see this stratified by males and females. You can see that as systolic blood pressure increases, the difference between a blood pressure of 110 and a blood pressure of 170 is really magnified for those who have other risk factors as well. So the treatment benefit is going to be even greater. So how do we use a risk-based approach? This is the algorithm from 2025. It kind of builds on the algorithm from the prior iteration of the guidelines. But essentially, if your blood pressure is over 140 systolic, initiate treatment. For those who are less than 140, considering whether they have clinical CVD or heart failure and whether they have an elevated 10-year risk, those are the ones that we want to encourage more immediate antihypertensive use to a goal systolic blood pressure less than 130. Whereas if they have maybe a lower cardiovascular risk overall, it's maybe less important to be aggressive right off the bat, and you can try lifestyle first. And importantly, in older adults who may be frail or have limited life expectancy, a clinician-patient assessment of potential benefits and harms of blood pressure lowering should be pursued to align with their goals. Now, what about people living with HIV? We don't have randomized controlled trial data, but we do have some observational data, this from Northwestern, showing that for initial treatment of blood pressure, beta blockers were associated with increased risk of cardiovascular events over time compared to ACEs and ARBs or renin-angiotensin system inhibitors. And this aligns with what we know in the general population. Generally, beta blockers are not great blood pressure medicines, so I'd encourage everyone to try to move away from that for initial use and maybe think about ACEs and ARBs as first-line treatment. Of course, calcium channel blockers and thiazide diuretics also having importance in combination treatment. Blood pressure does change with ART. And just looking at a modern integrase inhibitor regimen, for example, from the advanced trial, we saw certainly increases in systolic blood pressure in the dolutegravir TAF arm compared to the other arms, and increases in incident or emergent treatment emergent hypertension. However, these differences in regimens were attenuated after adjustment for the changes in BMI, which we know were present in the advanced trial. A few hypertension pearls here. ART certainly raises blood pressure, as we know, and from my perspective, the differences between regimens is actually pretty modest, as you saw from the last slide, and so that hypertension rarely merits a switch in ART. However, we do need to be clinically relevant or beware of clinically relevant drug interactions. And the one I'd point out is with amlodipine. The quality of evidence for this interaction is very low, according to the Liverpool checker. But I have certainly had clinical experience with patients on boosted regimens starting amlodipine at 10 milligrams and having a lot of lower extremity edema. So just something to watch out for. So how do we overcome our clinical inertia to get patients onto appropriate medications and achieve blood pressure goals? One approach that we've published previously is a nurse-led strategy, and you can learn more by stamping the QR code there if you want. This was a randomized trial of 300 people with HIV on antiretroviral therapy who had both hypertension and hyperlipidemia, randomized to this four-component nurse-led intervention, including nurse-led care coordination, nurse-managed medication protocols, home blood pressure monitoring, and electronic health support tools, with a primary outcome of systolic blood pressure and secondary outcome of non-HDL cholesterol. This was a hybrid type 1 implementation effectiveness design, and we have a lot of data on who and what sort of implementation metrics matter as well. But to get to the point, systolic blood pressure was lowered by 4 millimeters of mercury and non-HDL cholesterol by 17 milligrams per deciliter. And these are clinically important reductions, which would be expected to correspond to reductions in ASCVD events of between 10 and 15%. So an important, perhaps strategy for getting people to go in our clinics. So we have a few minutes left to talk about aspirin, to be comprehensive today. And so we know that several years ago now, back in 2018, there were a couple of really landmark trials that showed in the healthy elderly, the effect of aspirin on cardiovascular events was actually not that significant. This is the Aspirin trial. And you can see on the left, the effect for ASCVD events may be non-existent, if any, and there was a considerable increase in major bleeding. And so the pendulum shifted then towards away from recommending aspirin in older adults. So you saw a lot of things in the press about daily low dose aspirin no longer recommended by doctors um, if you're healthy. And we had to field many questions about our patients with established cardiovascular disease who definitely still need it. But in patients for primary prevention, the USPSTF in 2022 changed their recommendation to say that really it's just for people within the 40 to 59 age group with 10-year cardiovascular risk greater than 10%. And they recommended against initiating aspirin in older adults older than 60. But what about HIV? What might be different? And I think this is an interesting story around abacavir. We do occasionally still see abacavir use, so I think it's still relevant. As we all know, abacavir was associated with myocardial infarction and DAD, and it's importantly, just recently in a study of the Reprieve, also associated with risk in Reprieve. And the mechanism is thought to be related to increased platelet reactivity, such as in this study shown here on the right panel compared to TDF. And what is further evidence that it's platelet reactivity mediated is that in the DAD study, they went back and looked at people who had had a myocardial infarction, and some of them who stayed on abacavir versus others who didn't. When they looked at the risk of recurrent MI, they didn't see any increased risk of recurrent MI on abacavir. And the postulation or the hypothesis was that maybe it has to do with the aspirin that was prescribed after myocardial infarction. So, for whom do I prescribe aspirin? I think it's a very individualized decision, obviously, but I tend to favor middle-aged adults with HIV who are 40 to 59, who have an increased cardiovascular risk, who may be on abacavir, or since we talked about coronary calcium, those who have significant subclinical coronary disease. And these people have not had a cardiovascular event, but I don't really call it secondary prevention, and I don't really call it primary prevention. I'd call this group primary plus, and if their bleeding risk is relatively low, I would consider aspirin in that population. And I generally avoid aspirin for primary prevention in older adults. So what does the future hold? Well, we all know that we have injectable ART, but we now have injectable cardiovascular disease prevention in drugs that can lower cholesterol significantly, such as inclisiran shown here, or even antihypertensive drugs. There are now injectable small interfering RNA drugs that are being tested in phase 3 trials to lower blood pressure. So maybe in the future, we'll be coming in every 6 months for our ART, but also for cardiovascular disease prevention care. So in conclusion, I feel like we have a really an amazing opportunity, given the structure of HIV care in the United States, to provide high quality CVD prevention care as well. And I think we all want to take advantage of that. I think we need to emphasize the importance of shared decision making around statins and that it begins with risk prediction. Why? Because the magnitude of absolute risk reduction depends on the baseline absolute risk. And then finally, also consider absolute risk when establishing a treatment target for blood pressure. For those who are very much at lower risk, it is reasonable maybe to start with lifestyle rather than aggressively treating blood pressure off the bat. And then be cautious with aspirin in older populations. And then finally, it's really important to say just when you're thinking about the pre post test questions that you think about coronary calcium and the value in potentially helping someone who's on the fence about whether or not they want to take a statin. If you can do a calcium score and show that their risk is much lower because their calcium score is 0, that might actually help them decide, well, maybe I'll wait a little bit to start a statin medicine. All right, and that is it. I'll end my presentation there.
Great. That was fantastic. Thanks for the wonderful overview of kind of practical things to do in clinic. Along that coronary artery calcium score, kind of thinking about when you would incorporate it. So you mentioned if someone had a was trying to make a decision about whether to start a statin, you might check a coronary artery calcium to help sway them one way or the other. Um, if it's zero and they decide not to start it, is there value in repeating that calcium score in 5 years, or how do you kind of follow up to get them to eventually start a statin?
Yeah, that's a great question. I would say that if you have a score of zero, the likelihood that you're going to progress over the next 5 to 10 years is still relatively low.
Mhm.
But if you want to check it again, maybe down the line, ten years is a reasonable time frame. Once you have a positive calcium score, doesn't make any sense to recheck it. We know that statins actually increase the amount of calcium in the atherosclerosis. So there really is no role for serial monitoring of calcium scoring in patients who are on therapy. And again, if people are willing to take the statin without that extra risk stratifier, then there's really no role in that case as well.
And would you
So
ever do that if you had somebody who is already on a statin who really is concerned about cardiovascular risk and, should I start
should I
colchicine
go
or
to a
something else?
higher
Yeah, yeah,
should I go to a higher dose of
yeah.
statin, or how low should I drive my
Hmm.
LDL cholesterol? I think there's less evidence for that.
Okay.
Um, I would check something more like a lipoprotein little a in that case, especially in someone who had a family history. Lipoprotein little a is largely driven by your genetics, and it can be a significant risk factor for events. So if someone really wants to kind of risk stratify themselves. They're already taking a statin, but they want to maybe, take ezetimibe or something else to get their LDL cholesterol even lower. And LP little a is really helpful.
Okay. A lot of questions on coronary artery calcium in the chat here as well, or in the Q&A. Are they covered by insurance, or has that been an issue trying to get justification for insurance to cover these?
Yeah, I mean, I don't know the whole landscape across the entire United States, but in Washington State and in Ohio, generally it was not covered. In Ohio, where I practiced in Cleveland, we had a program through the hospital that offered it free of charge to patients who qualified. And it's generally fairly low cost, but again, even $99, which it was in many cases, is too much for many people. So yes, that is definitely a barrier.
And can you order an EKG gated CT screen for lung cancer, or is there a way to bundle those two to get insurance to cover it somehow?
No, I planted that question in the audience. Thank you for that. So what I do nowadays, I would say that I rarely order a coronary calcium score. Rather, when I'm seeing someone for primary prevention, I'm just combing through their entire chart to see if I can find any CT scan that they've had. Any non-con scan of the chest is going to show calcium, and I call this opportunistic calcium scoring.
Okay.
So you can look at the images yourself and see where the calcium is, but if there's any substantial amount of calcium, then you know the calcium score is not zero, right? And so it's been very helpful to do that. Even an abdominal scan sometimes can get the lower part of the heart and may show a little bit of you know, posterior descending artery or RCA calcium, which can also give you a clue. And I think radiologists are much more commonly now reporting on coronary calcium in those cancer screening studies. So if someone's a smoker and they have an indication for a lung cancer screening test, there you have your answer. You don't have to get a calcium score.
Okay. No, that's great. And so you would use them if someone is on the fence with a statin. Are there other times that you would just order one besides kind of the statin question?
Um, no, not
Okay.
that I can think of
Okay.
offhand, right? I mean, it's
Yeah.
really risk stratifying for cardiovascular disease prevention. I wouldn't say there's evidence for it in blood pressure management, but you could kind of maybe make the argument. But I think in general, most people use it for decision around statins.
Mhm. And I know this is more of a aging focused discussion, but do you have thresholds for which you'll start statins in people that are younger than 40 who aren't at that can't plug them into the cardiovascular risk score? Is it just that LDL of 190, or do you have other, is
Yeah.
there,
Well, younger people living with HIV will be living with HIV for a very long time, right?
yeah.
And so, relevant to this question of accelerated aging, I think that they are at increased risk. And I think traditionally we've thought of lifetime risk, and the prevent equations now calculate a lifetime risk for younger age groups. Um, and so if you are at elevated lifetime risk and you're LDL, this is where the actual cholesterol value matters the most, right? If your LDL cholesterol is 70, your elevated, your lifetime risk is still pretty low. But if your LDL cholesterol is like 130, 150, and you're 30 years old, I think it's reasonable to have that individualized discussion with a patient around starting a statin.
Mhm. On the other end of the spectrum, thinking of your frail older patients, do you have thresholds for which you would stop a statin?
Thresholds to stop a statin in an
Yeah.
L. Yeah. So I think that you talked about frailty and kind of end of life. I think polypharmacy at the end of life is really important, and not just the end of life, but as we age.
Hmm.
So I think it again goes to an individual decision. I do not have any hard and fast rule around that. If someone's ASCVD risk is driven entirely by age, if they're
Yeah.
70 years old, their ASCVD risk is going to be high no matter what, no, regardless of what their cholesterol is. If their LDL cholesterol is low, it seems to me it would be reasonable to de-escalate therapy if they wanted to, right? And not
Yeah.
to recommend a statin.
Especially in that frail patient that you're
Yeah,
trying to
especially in the frail
cut down
patient.
medications.
But again, using your walk test to identify those who are actually very robust and have many years to live, and feel free to continue to be aggressive about cardiovascular disease prevention in those patients.
Similarly, would you, I know you mentioned you would use aspirin in that 50 to 59-year-old. If it's a lower risk patient, or in whom would you stop aspirin once they hit 60?
Yeah, I don't necessarily recommend stopping aspirin.
Okay.
The USPSTF doesn't have any recommendation on stopping aspirin.
Hmm.
If someone has been on it a long time, they've kind of declared themselves in some way, about bleeding risk, right? If you've been on it for 20 years, obviously the risk is still there. But I think it's, reasonable to continue the aspirin use. Again, with shared decision. Um, and again, maybe aspirin is one where a coronary calcium score in the future may be particularly beneficial to de-risk someone and to stop statin use, or to stop aspirin use in that population.
And then can you clarify the prevent equation on when you would use that and whether it underperformed or overperformed, or just some details around that? There were some
Yeah.
questions as to
So
interpretation of
we
that.
have two studies that are just published that show that it underpredicts risk. And the criticism of the pooled cohort equations in the general population was that it was over predicting risk. But in HIV, because the HIV is associated with increased risk, what we see now is that the pooled code equations, at least in Scenics, seems to be actually fairly accurate from a calibration standpoint. And again, just distinguishing between calibration, which is it over or under predicting risk, and risk discrimination, which orders people in terms of their risk. I think the prevent equations can discriminate risk at levels less than 5%. So if you have someone who is less than 5%, who says, well, I'm kind of borderline around a statin, maybe doing the prevent equations. And if the prevent equations say that their risk is 1%, then they probably are really truly in that lower risk category. And the reasons they would be low risk is because they don't have kidney disease, they don't have albuminuria, their zip code SDI is not abnormal. So if that's kind of maybe the way to use it, is that less than 5 category.
Mhm. Um, and then any thoughts on the kind of side effect profile in statins that might be more pronounced in people with HIV? Have you seen a greater occurrence of muscle toxicity or cognitive effects, or thoughts on safety of statins for long-term prevention?
Yeah, I'm not aware of any good data on long-term risk of cognitive decline. I just want to make sure that that's very clear.
Mhm.
And that in many ways, by preventing vascular dementia, statins could potentially, benefit some people.
Yep.
Uh, in terms of muscle aches and pains, I have not seen any increased risk, except in patients who have drug interactions, right? So you have to be aware in boosted ART, you're not going to be prescribing atorvastatin at 80 milligrams. But if there's no drug interactions, I've not seen that increased risk of muscle side effects. Um, as shown in Reprieve, there was no increased risk, at least compared to trials of the general population. The rates of diabetes were similar. And so that's kind of been what I tell patients is I don't really see a lot of increased risk of side effects.
And then just one last quick question, in terms of lifestyle, can you alter a coronary artery calcium with lifestyle, or is that something that you really need a statin to alter?
Yeah, and again, going back, we don't think about coronary calcium as something to follow longitudinally as evidence of response to treatment.
Yep.
Um, but certainly, lifestyle can influence calcium. Um, I won't go into the major details, but some, performance athletes, for example, may have some coronary calcium, and maybe you think of that differently than in the average patient. But yeah, in general, lifestyle is very important. I'll end with that.
Excellent.
Thank you.
Great place to end. Well, thank you so much, Dr. Longenecker. That was fantastic. And I will turn it over to Dr. Badimo to introduce our next speaker.